All right, it looks like I am live on YouTube as well. And actually, let me go ahead and record it here. All right. All right, and Linda can hear me, and Elaine and Teresa. All right, we have Cheryl from New Zealand. Yeah, feel free to let me know where you're Zooming from. What I'll try to do also, see if I could go on YouTube. I do this when I live stream to Facebook, kind of go back and forth. All right. Just in case if there's any comments on YouTube, anybody. But yeah, feel free to let me know where you're from. And again, we have Cheryl from New Zealand, and we have is it Halo? It's hard to see. It's not just a unique name also, but also the comments are so small in Zoom here, or in the chat. So Halo from the Netherlands. And let's see, Lucy, hello from London. Lara, it's rainy and warm in North. Okay, so a fellow North Carolinian. Hey, Linda, good to have you here. Linda from Africa, and we got Robin from Southern Illinois, Julie from Worthing, UK, Teresa from Austin, Elaine zooming from Boston, strong. Okay, and Rupa from Bangalore, India, Renee from Atlanta, Catherine from Los Angeles. All right, good. And oh, there we go. Okay, and then on YouTube we have okay, snowboard chick from Nashville, Tennessee. Hey, Maureen, good to see you. All right, so we have looks like about 22 people or 23 people watching on YouTube. And all right, so this call really is for you. I mean, all these calls, when I do these random calls, it's for you. But, I've been doing a lot of Facebook Lives recently, and I just figured I know not everybody's on Facebook. I know some people here are on Facebook because I recognize you from the Facebook group. So if you are on Facebook, hopefully you're a part of my group. I have a new group that I formed a couple of months ago. There's a little over 2,000 people in there. So it's pretty engaged group. And for those who are not on Facebook, again, I just decided that I would do, every now and then I'll also do one on Zoom, and I live streaming into YouTube instead of, I didn't really have to live stream anywhere, but I figured I'd live stream into YouTube since it's been a few months since I did that. And so really just a lot of times when I do this, I have a presentation, and I could definitely talk about certain things, but let's see what questions have, and if they, so you could start typing it in the chat. And if there's not enough questions, I could definitely talk. I have plenty to talk about, but I really want it to be about answering questions. And related to Graves or Hashimoto's, preferably, since it's a Graves or Hashimoto's chat. And let's see, we got someone, Glenna, also from North Carolina, Mercy from New York. All right, so all right, and Terry from Tennessee. Okay, so we're gonna start. I'm gonna start with the Zoom, and I'll go back and forth between Zoom and YouTube, but I'll start with Zoom just because there's more people on Zoom, so I'll just use that. Usually there's more people on Zoom when I do a Zoom call streaming to Facebook. So Claudia here. So her question is, my block and replace treatment for Graves' disease. Oh, and if you're new to Zoom, there's a little chat feature, which again, in 2020, probably most people are familiar with Zoom. So maybe like a year ago, a lot of people aren't as familiar with this year with everything that's happened. I assume most people are familiar, but if not, there's a chat feature. And also, if you are kind of fairly new to Zoom and you don't want your name to show, you could hover over your video and there's 3 little dots. You could click on the dots and then you could just click rename. And then you could just, if you want to delete your your last name and just put your first name or make up a name or yeah, so let's see. So Claudia, my block and replace treatment for Graves' disease ends at the beginning of September. And block and replace, for those who are not familiar with that, they usually don't do that in the United States. That's more common in other countries. So that's when someone, typically with hyperthyroidism, Graves' disease, they're not only given antithyroid medication, but they're also given levothyroxine, the thyroid hormone. So they're given, the antithyroid medication is the blocking part, and then the replace is the thyroid hormone replacements. So Claudia was on block and replace treatment for Graves at the beginning of September. If I relapse, does that mean I will always have Graves' disease? And if I go into remission, does that mean it will never come back? I'm having a blood test soon to find out how it's going since I got off the medication. Thank you as always, Dr. O. So yeah, so when following conventional medical treatments, and that's what this is, whether you're taking, and this is both for Graves or Hashimoto's, if you're, just taking, if you have Graves and you're taking antithyroid medication, or you're taking, doing block and replace therapy, or if you have Hashimoto's and you're just taking thyroid hormone replacements, and if your numbers look good, that doesn't necessarily mean you're in remission. Now, it is a little bit different with Graves, because with Graves, typically what happens is the endocrinologist will, assuming the person doesn't choose to receive radioactive iodine or thyroid surgery, the person will be on antithyroid medication such as methymizole or overseas carbimazole or PTU in some cases. And then, they might be on that for a year and a half, 2 years. And then if everything looks good after a year and a half, let's say, the endocrinologist, meaning that what they'll do gradually is decrease the dosage of antithyroid medication. So they might be on 20 milligrams or sometimes a real high dose, like 40 milligrams. Dose will decrease over time. So, down to, let's say, 5 milligrams, maybe even like half a tablet, 2.5 milligrams. But they will be, eventually, hopefully the endocrinologist and the patient will hope that they'll be off the meds. And the endocrinologist will usually consider that a state of remission. Now, depending on the endocrinologist will, just about everyone will want to do at least one blood test off of the antithyroid medication. And if the person still looks good, their numbers look good, then the person will be, considered to be in a state of remission. The problem is that it's usually temporary. So Claudia asked, if I relapse, does it mean I will always have Graves' disease? And if I go into remission, does it mean it will never come back? So if you don't do anything to address the immune system component, then there's a good chance it'll come back. And this is statistics as well. So it's not just me saying this. Most people who get into remission or so-called remission from just taking antithyroid medication, eventually they relapse just because nothing was done to address the cause of the problem. So that's one of the big issues with just taking antithyroid medication. As far as if you relapse, does it mean you always have Graves' disease? So, with both Graves and Hashimoto's, there are genetics behind it. So even, many of you know, I dealt with Graves' disease. I've been in remission since 2009. I'd love to say I'm permanently cured, and it does feel like that way, but there's always a risk of relapse. And again, this is with both Graves and Hashimoto's. So you always need to do things to maintain a state of wellness. It doesn't mean that, I'm definitely not as strict, for example, with the diet as I was when I was trying to get into remission. But I'm not like I was before I was dealing with Graves' disease. So to answer your question, once you're in remission, it doesn't guarantee it will never come back. Even if you follow a natural protocol, like myself, there's no guarantee it won't come back. That's why I need to do things to maintain my health. But especially if you're just taking a medication, obviously what Hashimoto is usually what most medical doctors do, or endocrinologist or whatever, whether it's endocrinologist or general practitioner, they'll just recommend thyroid hormone replacement which again might be necessary. So I'm not saying conventional medicine is not, sometimes it is necessary, but it's not doing anything for the immune system. All right, so question here about thyroid eye disease. And so this person asked it privately, which sometimes it's an accident. Some people just aren't too familiar with Zoom. So so it might not meant to be private, but if it's sent to me as a private message, I'll read the question, but I just won't read the person's name, and nobody in the chat should be able to see it. But anyway, so this person asked, wondering if thyroid eye disease is the same as Graves' disease or if they're separate and apart. So thyroid eye disease, it's the same. It is an autoimmune. It's autoimmune, and typically it does involve the same autoimmune component as Graves. So you have with Graves, elevated thyroid stimulating immunoglobulins, which typically will bind or stimulate the TSH receptors, and that will lead to the excess production of thyroid hormone. So with thyroid eye disease, you've got the immune system attacking the tissues of the eyes. And again, it's the same autoimmune component. So typically, as you try to address the cause of Graves' disease, you're also addressing the cause of thyroid eye disease. The challenge, though, if someone has, let's say, severe thyroid eye disease, that even if we restore the health of the immune system, we might not be able to get the eyes completely back to normal. Again, it depends on the severity of the situation. Now, this in 2020, early this year, there was a newer drug, Tepeza, that was introduced. Again, ideally, we want to try not to do it through medication, but at least there is that option, although it is at least an option in the United States. I know some people in different countries told me it's not, like, I think even in Canada, someone told me it's not available, but there's something else going on, something else they're doing in Canada that sounds similar to Tepeza. All right, so let me just scroll through the comments and get to the next question. Okay, and what I'm also going to do, just to let you, also I didn't make this announcement, but I'm going to try to get to everybody. No guarantees. I'm going to try to get to everybody at least once. So again, I did a Facebook Live yesterday, and I got to most people at least one time, and I was on for a while, and didn't get. I know I didn't get to all questions, but same here. I'm going to try. So if someone asks multiple questions, I might get back to you again, but I'm going to try to get to everybody at least one time. So if you have multiple questions, I would try to ask the more important question first, just to make sure I get to you. Okay, and as far as methimazole spelling, yeah, it's prescription drug methimazole, Methimazole. I believe I've seen it like thousands of times, but I'm trying to visualize it. I'm better when writing things down, but yeah, it's methimazole. And then Renee has a question. What are some ways to lower your TSH naturally? So she has a higher TSH. TSH 4.8. Is 4.8 even considered very high? So 4.8, that's what some labs, a number of labs would still consider that to be within range, but it's definitely great outside the optimal range. TSH, again, whether you have hyper or hypo, whether they have Graves, Hashimoto's, optimally you want to see TSH between 1 and 2. And a lot of labs, their range goes up to, sometimes they'll go up as high as 5. And so 4.8 might be within your lab range, but yeah, a little bit high. So as far as how to lower TSH naturally, so I mean, thyroid hormone replacement, is not, sometimes is necessary, but that probably would be, and again, that wouldn't be my solution, long-term solution, because it's not, addressing the cause of the problem, but sometimes it is necessary. And now you could take like desiccated thyroid or glandulars, for example. And so those are more natural ways of lowering it, but it's still not addressing the cause of the problem. So if someone has Hashimoto's or immune system is damaging thyroid gland, and as a result, they have elevated TSH, of course, you want to do things. Remember, I'm sure most of you know this, but still a lot of people think of Hashimoto's and Graves as thyroid conditions. Again, they're immune system conditions that affect the thyroid gland. So if someone has Hashimoto's, elevated TSH, someone might need to take thyroid hormone. or again, desiccated, well, synthetic thyroid hormone a lot of people take, but again, there's other options like desiccated thyroid hormone, Armor, Nature Thyroid, WP thyroid, glandular such as Thyrogold, GTA Forte, but all these are, they're not doing anything for the immune system. So you want to always try to find triggers, remove triggers, heal the gut, correct underlying imbalances. So many of you have heard me talk about the triad of autoimmunity. And with the triad of autoimmunity, there's 3 factors that are necessary in order for autoimmunity to develop. So one factor is genetics, and obviously we can't change genetics. So number 2 is exposure to 1 or more environmental triggers. And number 3 would be an increased intestinal permeability or a leaky gut. So it makes sense in order to restore the health of the immune system, we would want to find and remove triggers, heal the gut. There could be other imbalances, and usually there are other imbalances that also are important to correct. So like, for example, if someone has nutrient deficiencies, that's important to address. It might not be a trigger to have, like, let's say a selenium deficiency, but if you don't correct that, you probably won't achieve an optimal state of health. All right, so let's see. Like I said, I'm going to try to get to the challenges, remembering who asked questions here. So I could try to get to, well, here. So this LDN, low dose naltrexone, this is a pretty common question. It would be surprising if I didn't get multiple questions on this, because a lot of people ask this whenever I do these calls. So LDN, low dose naltrexone for Graves. So again, I'll answer it for Graves and Hashimoto's, because it could apply to either one, either condition. So low dose naltrexone, which I've written a blog post and a few blog posts, but an updated one earlier this year, first half of the year. I think it's 5 things to know about LDN and thyroid autoimmunity. So low dose naltrexone, it is a medication. It does require a prescription. And what it does, it modulates the immune system. And so as far as my take on it, when it works, it could work really well. And it could, in some cases, even be a substitute for medication. So for antithyroid medication or thyroid hormone replacements, the problem is it's more hit or miss. So if it works, great. If not, then, especially with hyperthyroidism, if someone has, we can make the argument either way, but if someone has elevated thyroid hormone levels, you want to get those levels down quickly. You don't want to just, some people I know have unmanaged hyperthyroidism for a while, but that's not ideal for a few different reasons. So that's, the antithyroid medication, definitely there's a greater chance of side effects, but it almost always works. And that's why it's the first thing endocrinologists will recommend. Many of you know that I use bugleweed and I didn't take antithyroid medication. And again, I'm not against antithyroid medication. A lot of my patients take methymizole or another type of antithyroid medication. Those would, of course, hyperthyroidism and Graves' disease. And I never tell them just, stop taking your meds and switch to bugleweed. If someone wants to do that, of course, I'll talk to them, talk to them about it. But, risk versus benefits and, my approach. But, so LDN, if someone is unable to tolerate antithyroid medication, and let's say the bugleweed doesn't work because it doesn't work for everybody, then it might be an option. There's other options too, but that's an option. And again, Hashimoto's also might be an option for some people. But also just remember, and I talk about this in a blog post, is that LDN's not, even though it's modulating the immune system, it's not addressing the cause of the problem. So some people fall into the trap where they take LDN, and when it works, it, again, like I said, it could work well, and they just stay on the LDN. And, not that there's anything wrong with, it's sometimes could be challenging to find, remove triggers. It's not easy to do all that. So, sometimes it's, honestly, it is easier to take the LDN if it's working, but ideally, I definitely don't look at it as a long-term solution. So while even if someone's taking low dose naltrexone, and if it is helping, I still would do things to try to find the underlying cause and not just rely long-term on LDN. and sometimes it does lose its effectiveness over time. So if you're just, if you take LDN and it might work for a few months, maybe even in some cases a few years, but then if it starts losing effect, if it does become as effective, then then especially if you have Graves, if you're unable to take the antithyroid medication, that's why you took the LDN, and then it's not effective anymore. And if you haven't done anything to address the cause of the problem, you're more likely, I mean, your endocrinologist is going to, definitely or almost definitely pressure you to get radioactive iodine thyroid surgery, which again, they a lot of times will do anyway. But let's see, Melissa, I would like to hear your recommendations about an iodine protocol. So a lot of controversy with iodine here. So, and there's actually a documentary that came out on iodine recently. So iodine. So I'm not going to talk about specific iodine protocols because honestly, not yeah, iodine. First of all, iodine is controversial, and I'm not against iodine. Um, so my story actually, when I was dealing with, so some of you are probably familiar with Dr. David Brownstein. He has a book, Iodine, Why You Need It, Why You Can't Live Without It. And, like 10, 15 years ago, just a lot more people were on the iodine bandwagon, where people were like, oh, you got to take iodine. And not only did you have to take iodine, but you had to take like higher doses of iodine, like 25, 50 milligrams of iodine. So, and there's still practitioners that do that, and there's still people who just do that. And um, so my experience with Graves, I worked with one of those practitioners. This was in 2008 when I was diagnosed. And and before that, I would attend seminars. I attended nutritional conferences where, again, they were in favor of iodine for for hyperthyroidism, for pretty much all thyroid conditions, and just in general, so long story short, when I worked with the practitioner I work with, she was in favor of iodine, so she recommended an iodine protocol. And the iodine, so I'll talk about the iodine protocol that she recommended for me. The iodine protocol she recommended. So there's, a lot of doctors recommend iodoral, which is potassium iodide, and they'll recommend that comes in like 12.5 milligram tablets. And again, some people are on like 50 milligrams relatively quickly. Some will start slower, which is still really high, like 12.5 milligrams. So she started me on 3 milligrams, a different product called prolamine iodine, which actually has changed its formulation, so you can't get it in 3 milligram tablets anymore. But she started me on that, and I worked my way up to, and also did testing too. So I should mention, she did a urinary iodine test in me again. This was 2008, and she recommended higher dose iodine, and I was taking 9 of those tablets per day. I built up to that over time. So I was taking 27 milligrams, which is a real high dose. Some people take a lot more than that. And I honestly did fine on that. I did well. And for the next few years, after that, 2009, when I got into remission, then I started working with others, with Graves and as well as Hashimoto's. And so I was on the iodine bandwagon, and I would recommend iodine. And so, and I'm not, again, I'm not saying I never recommend iodine, these days, but definitely more cautious with, I realize not everybody does well on iodine, and, iodine can also potentially be a trigger. So I initially, in most cases, I don't really do much with iodine. So it's not like someone sees me and that's, I mean, yeah, it's not where I say, okay, let's test for iodine. Now, if I do recommend iodine, like supplementation, I would do like urinary iodine testing. But again, what I try to do, and I wrote an article. This is 4 years ago, so probably time for an updated article. But and it's actually entitled, I think, an update on iodine and an update on iodine and thyroid health. And I was just talking about why some people don't do well with iodine. It's, iodine causes oxidative stress, and a lot of people don't have the antioxidants. But with that being said, do we really need to take like 50 milligrams of iodine? Again, and maybe some people do, I don't know. But On average, I don't think most people need to take like super high doses of iodine. But anyway, so I'm not gonna. I could spend like a whole this whole call like just talking about iodine. I know for some people it's interesting. Others are like terrified because, and then some people, the endocrinologist is like, don't do anything with iodine. I'll have people will ask me, should I avoid a multivitamin, like the other extreme? Should I avoid all iodine, even in a multivitamin or any food source? And I usually don't go that extreme. Like, one could argue that maybe like higher food sources like seaweed in some cases could be a problem. The thing is, I will say this, everybody's different. So again, I took real high amounts of iodine, nothing bad happened. But I have seen, like with Graves, there's been a few people who, thankfully, I don't think any of my patients, but people just emailed saying that they took higher doses of iodine and it worsened their thyroid eye disease, like for example, which is not good. And then, people with Hashimoto's where, they took it and, that was the only change and their antibodies like skyrocketed. So again, I'm not against iodine. And, if anything, I think any mineral or any nutrient deficiency should be corrected. But I am cautious. So it's not, I don't, typically that's not going to be like one of the first approaches. Okay, we got to, with Graves or Hashimoto, say, yep, let's go ahead and, test for iodine and, and then put someone on like, very large doses of iodine. But anyway, like I said, check out the article, even though it's a number of years old, it's still, some of it's still relevant. Some of it probably does need to be updated. Probably won't be this year, but maybe in 2021, I'll do an updated iodine article since there's a lot of questions on that. But let's see. All right, looks like there's a lot of questions here. Just going to quickly go over to YouTube and just see. Wow, number of questions on YouTube. Okay, so 46 on YouTube. I think there's like close to 70 on Zoom. So let's see. So I'll answer a few questions on YouTube and then I'll go back to Zoom. And all right, so how does subclinical hypothyroidism cause joint pain? And this is from Paul. Why does subclinical hypothyroidism cause joint pain and implications on thyroid function? If ashwagandha totally reversed prior joint pain? Not 100% sure if I understand your question. So you took ashwagandha, which, I love ashwagandha. It is a member of the nightshade family. So nightshade sometimes actually will cause joint pain, but a lot of people do tolerate ashwagandha, not everybody. So it's just, kind of, I haven't heard of anybody say where ashwagandha actually reversed joint pain, though. Usually that's not what it's for. Usually it's like to support like adrenals, for example. But so ashwagandha totally reversed your joint pain, but then so subclinical hypothyroidism caused joint pain, implications on thyroid function. So I mean, typically, I mean, I won't say a lot, but some people with both hypothyroidism, even hyperthyroidism, have joint pain. It's usually not the result of the thyroid hormone imbalance. It could be a result of underlying, trigger or imbalance that could be responsible for a thyroid or immune system. So like most case, or at least a lot of the cases of Hashimoto's are subclinical, where they'll have elevated TSH, elevated antibodies, let's say elevated thyroglobulin and or TPO, thyroid peroxidase antibodies, and thyroid hormone levels look good, at least according to the lab reference range. Again, like as I mentioned, there's optimal ranges, and a lot of people within the lab range, but outside optimal range. But again, that typically won't itself result in joint, like if some, even if it's overtly hypo or overtly hyper, it's usually not going to result in joint pain, itself. But that, again, a number of people do have joint pain. It's usually not just the thyroid hormone imbalance. Usually there are other things, it could be infections, like I dealt with chronic Lyme disease a couple of years ago, and that could cause joint pain, certain, just inflammation in general. And, that's also something to keep in mind with both Graves and Hashimoto's. Even though, again, arguably everybody with these conditions have inflammation, which can lead to joint pain. Not everybody experiences the same symptoms. So that's also, just again, just getting away from the, that it's a thyroid condition, but more of an immune system condition. And again, inflammation, there is an obvious connection between immune system and inflammation. And so what you really need to do is try to find out what's causing the inflammation, what's causing the autoimmune response. Again, easier said than done. Definitely, definitely check out my, website. Many of you have plenty of articles, and also my books on hyperthyroidism, Hashimoto's, if you want to dig deeper. And, also, again, we'll see what other questions come up. That's why I'm doing this, but, just a single, these calls, there's only so much depth I could get into, but like I said, I'll try to give as much information as I can based on the questions. And Maureen, do you recommend any herbs or supplements if a person is not on meds and they have Hashimoto's? I mean, I'll commonly recommend, a lot of practitioners, or not endocrinologists, but functional medicine practitioners, will recommend supplements, even if someone is on, let's say, thyroid hormone replacement or on anti-thyroid medication. So yeah, I will recommend supplements, and some of it will be general. Like I commonly will recommend like omega-3s and probiotics, and if someone's deficient in vitamin D. But then, it also, some of it depends on the person's specific imbalances. Like again, vitamin D is one. Most people are lower in vitamin D, but yeah, I'm one that likes to look at testing. I do give some supplement recommendations initially, like during the first consultation, but I don't like to just randomly say, here, take like 10 different things. And I know a lot of people do that just because we're exposed to so many things on the internet. So you might watch a video and hear someone talk about a certain supplement like this. This on Thursday, I actually wrote an updated article or updated blog post. But you could, one of the things I spoke about was black cumin, and I wasn't talking about black cumin to like encourage everybody to go out and get black cumin, but I was talking about some of the benefits. But some people, I'm sure, read that article, read that blog post, and it's like, wow, I need to go out and get some black cumin. And I can understand, actually, in that case, it's just like for immune system health, and talk about viruses. And I think I did say where it's a good thing to kind of have on hand, just like not necessarily take it, but there's so much information out there, and people, including myself, I talk about supplements sometimes, but it's, just here again, I'm going to talk about it based on people's questions though. And yeah, so but yeah, I do recommend try to do as much through diet, of course, as well. You don't want to just load up on supplements, and common sense, I assume most people know that. But and then actually Chris asked what supplements to take for Hashimoto's. And again, it really depends on what is, my goal is to try to find out the triggers, the underlying imbalances. Again, there's some general ones, like a lot of people will take, for both Graves and Hashimoto, selenium is a popular one. So taking like selenomethionine, for example, and there's other forms as well, but that's one that I commonly recommend. And so speaking about selenium, if you have not seen, for those who are on YouTube, or even if you're not on YouTube, I did an interview last, those on Zoom, or it doesn't really matter where you are, but just I'm looking at some of the YouTube questions. And so I did an interview, actually it was on Facebook, with Dr. Kasha Kynes. This was 2 weeks ago. She's author of the book, The Epstein-Barr Virus Solution. And so it's on Facebook, but it's also uploaded to YouTube, my YouTube channel. And I did send an email. I sent the video out to everybody on the email. So a lot of you probably have watched it, or at least got the link. But we spoke about selenium, and I've always been nervous about higher doses of selenium. Usually I recommend 200 micrograms to my patients, just because I'm worried about selenium toxicity. But she was talking about how she recommends and this, I know this is a Hashimoto's question. I'm talking about Epstein-Barr, but there is some well, Epstein-Barr could be a factor with Hashimoto's, which is why I interviewed her, because it could be a factor with Graves or Hashimoto's. But anyway, with selenium, I commonly recommend 200 micrograms, but she was talking about how she commonly recommends 600 to 800 micrograms, which is, to me, really high. And again, she wasn't talking about Hashimoto's, but with Epstein-Barr. Now, in some cases with thyroid eye disease, I'll recommend higher doses. But anyway, so selenium. So just, I'm getting off a little bit off track, which I have a tendency to do. But selenium, probiotics, omega-3s in the form, if you're not a vegan vegetarian, like fish oils. If you are a vegan, maybe like algae oil. But vitamin D, you need healthy vitamin D levels. And things a lot of times to increase glutathione, which is the master antioxidant, and that supports phase 2 detoxification. I might recommend, depending on the person, like NAC, N-acetylcysteine. These are some of the more common ones, but then, if I do adrenal testing, it will depend on what their adrenals look like. If I do other types of testing, also, I'll look at, so again, it really does. But if, for those with Hashimoto's, and honestly, even those with Graves, you might want to check out my book, Hashimoto's Triggers. Again, not trying to plug my book, but, I'm, again, just, it'll answer a number of questions. And, the Kindle, if you get the Kindle version, it's like only $6. But I talk plenty about, the whole book's, the goal is not to talk just about supplements, but like towards the end, when talking about recommendations, I talk about food, but also, talk about supplements too. So if you want more specifics, you should definitely check out the book if you haven't already. It's a real large book, so try not to get intimidated. It's over 500 pages. It doesn't mean you don't have to read it from front to back, but I definitely would check that out. It's of course it's my book, so I'm going to be biased, but I wrote the book not just to have a book. But I just wrote it just because I wanted it to be the most comprehensive book on Hashimoto's, and I think I accomplished that. But that's for you to judge. And then I'm hoping to come out maybe next year or the year after with another updated Graves' disease book, because it's been a while. I came out with it in 2011 and then updated in 2013. But there's definitely some updates I'd like to make. It's just again, the time to write a book. And just what I did with Hashimoto's Triggers, I focused on that just because I already had a book on Graves, and I started that like in 2015. And so it took me a long time to put that together. So, same thing with Graves. If I write an updated book, I wouldn't want to, even though I'd be using maybe some of the information from the first book, but point is, I wouldn't want to just rush it just to get it out. So honestly, 2021 is probably pushing it, but it is on my radar in the future. Okay, I'll answer this question. Then I'm going to go back to the Zoom questions. What about the keto style eating plan? Would you make that as a suggestion? Ketogenic, so that's, higher fat, lower carb. For Graves and Hashimoto's, so let me say this before I talk about diet. There is not one diet that fits everybody perfectly. So when I give diet recommendations, it's more of a starting point. And anytime, like with any diet, there's going to be people, whether it's ketogenic or autoimmune paleo or regular paleo or whatever diet, there's going to be people that, now there's like carnivore diet. There's going to be people who follow the diet and they're like, wow, this diet was amazing. I just got amazing results. And then there's going to be other people that just like, I just felt horrible on this diet. And then, so I commonly recommend autoimmune paleo as a starting point. But that's all it is a starting point. And I can't say everybody follows that, every one of my patients follows that. For some people, it's too restrictive. Someone's a vegan, vegetarian, usually we're going to have to we'll make modifications. But even if someone's not a vegan, vegetarian, it could be restrictive. So ketogenic is also good. Again, it's not something I commonly recommend for Graves and Hashimoto's, but, if someone, is trying to lose weight, helps with, helping with insulin sensitivity, increasing insulin sensitivity, decreasing insulin resistance. None of these diets I don't look as long-term diets though. So ketogenic, autoimmune paleo, you know, if someone, if for those who follow it, I do look at it more short term, like a few months, not again permanent diets, or not a permanent diet. So let me go back to Zoom here, and all right. So all right. So Michelle, what is the one greatest piece of advice uh, for someone with Graves, 50 plus year? Okay, 50. Oh, 50 years old. Okay, I thought 50 plus years with Graves. I'm like, wow, that's I think that would be a record that I've seen. But so, okay, for Graves, 50 plus years old, suffering with weight gain versus weight loss. Greatest piece of advice. So are you going back and see, I'm not sure what the, like, are you fluctuating back and forth between weight gain, weight loss? Are you on antithyroid medication? Because, you know, like a lot of people lose weight with Graves, not everybody, but if someone's losing weight, but then they take antithyroid medication, you know, and that a lot of times will cause the person to gain weight. And then, you know, the dosing over time will change, you know, they'll usually gradually decrease. And, you know, so what I will say is you want to balance. First thing you want to do is balance the thyroid hormone levels. When it comes to Graves and weight, you know, especially weight loss, you know, if someone's losing weight, you need to balance thyroid hormone. You know, someone will say, well, you know, what can I eat to gain weight? And it's usually that's not going to, I mean, yeah, eating nutrient dense foods is always a good idea, but usually you need to, I mean, again, I lost 42 pounds when I was dealing with Graves' disease, and some of my patients gain weight. You know, I realized that, but you know, the biggest thing was elevating thyroid hormone. Well, I'm sorry, was lowering thyroid hormone levels. I already had elevated thyroid hormone levels, which is why I had the increased metabolism, and I lost 42 pounds. But you know, so normalizing thyroid hormone levels. Also could be absorption problems too. So healthy gut, healthy digestion and absorption. So that could also be a problem with weight loss. And then with weight gain, again, if you're not taking antithyroid medication, you know, so probably a big factor, or not probably, a big factor. A lot of people already know diet, exercise, and many people have already done that. But blood sugar, adrenals, inflammation, toxic load, you know, if you have, you know, elevated cortisol levels, if you have, you know, higher toxic load, if you're, you know, have a high amount of inflammation, you're going to have a hard time losing weight, even if you eat a really restrictive diet and if you exercise regularly. So when it comes to weight gain, there's those other imbalances are almost always in play. Again, adrenals, blood sugar, you know, toxic load, um, inflammation was the other one I mentioned. Again, gut microbiome, just have a healthy gut microbiome. Again, not easy. So I'm not saying all these things are easy to do, but yeah, so those, and then again, weight loss. If you're losing a lot of weight, then you need to get those thyroid hormone levels lower and also focus on improving gut health. All right, so Lara here has her question. Is it safe to get off medication? I've been on it about 15 years, Nature Throid, 97.5, 6 times per week. I'm 68. Yeah, so again, I did mention, which is true, you know, if you have Hashimoto's, which it's Graves and Hashimoto's chats, I assume most people have Graves or Hashimoto's. There might be some people, you know, just straying in here, just, you know, just learning, who have another thyroid condition. I mean, pretty much most people on my list have, you know, some type of thyroid condition, but either way, it's, yeah, I mean, that's, you know, that's definitely not like a lower dose. So, and I can't just tell someone to get off the meds, but you know, is it safe to get off the medication? Um, so I'd be cautious about just like stopping cold turkey with something like that. You know, just similar if someone was on like anti-thyroid medication for Graves, and if they were like on 40 milligrams and they just said, can I just stop? I mean, you know, different situations. I mean, I guess the situation, if you did do that and, you know, you needed it, you probably would become pretty hypo. And, but I mean, so my approach when it comes to, both Graves and Hashimoto's, obviously address the autoimmune component. With Graves, it's a little bit of a different story because we're not getting damage to the thyroid gland. So, just about everybody is able to get off the medication. When finding, like when we're restoring the health of the immune system, pretty much the people don't need to take anti-thyroid medication. With Hashimoto's, it depends on how much damage has been done to the thyroid gland. And if you have Graves, you might think the Hashimoto's part is irrelevant, but just keep in mind, a lot of people with Graves disease have Hashimoto's antibodies, and if you haven't had the Hashimoto's antibodies tested, you might want to consider doing that just to see. I'm not saying it's mandatory to do that, but and those are anti-thyroid globulin antibodies, thyroid peroxidase antibodies. But point is, with the when someone has Hashimoto's and its immune system is damaging the thyroid gland can regenerate. It's just not as good as regenerating as liver and gut and some other areas. So again, it depends as far as someone getting off a thyroid hormone replacements. Yeah, it's definitely possible, but it depends on, obviously finding and removing triggers and healing the gut. But even if we accomplish that, depends on how much damage has taken place to the thyroid gland. And a lot of that is dictated by the dosage someone takes. Usually it's not necessarily how long they've had it for. If someone's on a lower dose of thyroid hormone replacement and they've had Hashimoto's for 20 years, arguably it would be easier to get them off of the thyroid hormone, get them to the point where they don't need the thyroid hormone, compared to someone who's only had it for a couple of years and they're on a real higher dose, of whether it's desiccated thyroid, such as Nature-Throid, or, levothyroxine, such as like Synthroid or Tirosint. So yeah, it's as far as it's hard to give you an answer, Laura. I would say in most cases, probably not safe just to, just to stop. You probably wouldn't want to just abruptly stop taking it. I mean, what I look for in my patients is with both like if someone takes thyroid hormone and they don't need it, they're going to start becoming hyper, and if they become hyper, then you start reducing the dose, and it's a gradual process. Same thing if someone is hyper and they're taking something anti-thyroid, whether it's methimazole or bugleweed, if someone takes those and they don't need it, they're going to start becoming hypo. So again, and that's where, you typically don't go from like a high dose to like zero. You're going to want to gradually, decrease, and that's based on, the numbers. Going to want to test the, TSH, free T3, free T4 regularly. But again, make sure, hopefully you're doing things to address the cause of the condition, because that's, if you are to get to the point where you don't need thyroid hormone, you're going to need to address the cause of it. In most cases, there's always exceptions. My mother, there's no, even though I had Graves, there's no family history that I know of Graves. My mother told me that she was on thyroid hormone replacement like 40 years ago. And she said, again, I have no, obviously I was just a child then, but so I have no idea, no recollect, but she said she just stopped. So she's not on thyroid hormone now and hasn't been on for years. So she stopped and she was okay. So I can't say it's never okay, but anyway, in most cases you want to, in most cases you probably don't want to just abruptly stop. At the very least, maybe work with a, functional medicine practitioner, to help you with that. Let's see. So Julia, all right. Julia, how can one safely transition to natural methods if your values are high? So for example, if you're on 40 milligrams of carbimazole, yeah, and that is a high dose. So when you get to the 40 milligrams, it is a little bit more of a challenge. Like if someone wants to go from carbimazole to like bugleweed or carbimazole, for those in the United States, carbimazole is typically used overseas and it converts to methimazole. So 40 milligrams of carbimazole, just like 40 milligrams of methimazole, is kind of on the higher side. I've seen some people higher, but some people on like 60 milligrams, which is not too common. But yeah, so I mean, the approach I take if someone wants to make the transition, if they're on anti-thyroid medication, I'll put them on the bugleweed at the same time. And then, like I said, if someone doesn't need, we would want to see them hypo if they don't need, if they're getting too much in their, we don't want them to be super hyper, super hypo. Although sometimes just the 40 milligrams of antithyroid meds alone will make them super hypo. But assuming they're on 40 milligrams and then again, another blood test. And again, let's say their levels are looking good. They're not hypo, but they're looking good. And if they want to get off the meds quicker than later, again, I won't tell them to get off the meds, but I would say that's your goal. And you're, obviously they're working with someone who's writing that prescription. So I'll give them, I'll say, I would take the bugle weed at the same time, maybe not at the exact same time, like, like space it out a little bit, but then as someone, is on both, and the goal, hopefully you're becoming more, not super hypo, but on the hypo side. And then when you see your doctor, in your case, your carbimazole dosage will be reduced, and that, so that's the goal. So yeah, I wouldn't say to just be on bugle weed, for like 2 weeks or 3 weeks or a month, and then just stop taking the 40 milligrams. I know that's what some people want to do, and maybe, you could do that relatively quickly, but in this case, again, a good idea to work with someone, but again, that's kind of the approach I take. Let's see here. So, all right. So let me say, we have like a crazy amount of messages. So I'm going to go. So initially my goal was to go till 4 o'clock my time. I'm going to go until 4:30, and I'm almost definitely, there's going to be a lot of questions. So I'm going to do, I'll try to do a few more of these, like try to do these a little bit more regularly, and not necessarily always on a Saturday, but just different times. And then, yeah, so if I don't get to your question, I will be doing other ones of these. It's not official yet, so I wasn't really planning on making an announcement here, but just because there's so many questions, and I feel bad when I can't get to all questions, but I probably would have to be on for like 3 or 4 hours. But so some of you are familiar. I've had some challenges in the past. I've had actually 3 this year, 2 long ones and 1 short one. So I'm pretty sure, but I haven't, made any announcement yet. Still need to do some work on, I'm thinking about doing another challenge in early November. So it would be a 21-day challenge. And so and again, for those who have been part of my past challenges, especially the longer challenges, I had a free 5-day one in August where we had like 1,500, close to 1,500 people like join that. So the longer ones, typically not as many participate, which is kind of, so you get more, but more individual attention. So you might want to consider that. Again, I'm probably going to do it, just haven't committed yet. So I'm bringing it up here. So I guess, and I did bring it up yesterday also, just because we were like, same thing, same scenario. Whenever I do these, I get so many questions. But that's an opportunity where and pretty much everybody who attended, you'll see when assuming I do go through with it, which I probably will, there's like testimonials, and they all say like, I just over deliver, and pretty much everybody gets their questions answered. But like I said, I'll also do some of these, this month as well. Just it's just been a really busy, which I'm grateful for. But anyway, so yeah, I could just see I won't get to every single question here, and I apologize in advance. But so anyway, let me get back to questions here. So Julia, how can I safely? Actually, I'm sorry, I just answered Julia's questions about the transition. So Micheline, I have a question about my fluctuating numbers and symptoms that seem to get worse as my hyper numbers get better. Also wondering how sodium intake affects my symptoms. I have no kidney issues, but my eyes seem to suffer with sodium, and as my Graves numbers go down. Yeah, so I'm not sure. Really, the only question you had is about sodium. You said the first one, I have a question about my fluctuating numbers and symptoms that seem to get worse as my hyper numbers get. Oh, as your hyper numbers get better, your symptoms get worse. Yeah, interesting. So I guess, my question would be, are you on antithyroid medication? Because if you're on antithyroid medication, you're becoming more hypo. then, that your numbers could go down, but again, that could cause you to get worse. If not, it would make me think there's something else going on. If your numbers are improved, I know as my numbers improved, as my hyperthyroidism improved, I definitely didn't feel worse. And that's the case with most people. But if that's the case with you, sounds like there might be something else going on. Now, sodium, you brought up an interesting question with sodium. So sodium, again, I do recommend like sea salts, natural sea salts. I will say though, a few things about sodium that's interesting. So one, I commonly recommend a good quality sea salt, such as Celtic sea salt. And I mentioned it was like recent iodine documentary where it was, so Celtic sea salt apparently is good, but then pink Himalayan sea salt, which I didn't know that apparently is higher in iodine, because someone had the iodine question. But so maybe just make the transition to switch to Celtic sea salts if you're concerned about iodine. But with sodium in the literature does show, like if too much sodium will potentially be a trigger, can increase Th17 cells. I wrote about this in my Hashimoto's triggers book, not in my hyperthyroidism Graves' disease book. It's not in there just because I didn't come across the research until after. Again, another reason why I need to write an updated book, but and another reason why, again, some people with Graves, you might still benefit from the Hashimoto's triggers information because not all of it's specific to Hashimoto. So with the salt, yeah, and salts, and I mean, if you're not eating whole healthy foods, if you're buying almost any type of packaged food is going to have sodium in there. So yeah, just as far as like sodium affects your symptoms, that could be stimulating your immune system, causing problems. So again, I'm definitely a fan of like natural sea salt, Celtic sea salt, but yeah, you might want to be cautious, just everybody in general, about sodium intake, just not overdoing it. And again, if you're eating mostly whole healthy foods, then it's not as big of an issue. But if you're eating a lot of packaged foods, even organic gluten-free foods, they're still going to typically have sodium, and it's going to add up if you're having that throughout the day. All right, so Mayoa asks, and I hope I pronounced your name right, must I undergo radioactive iodine therapy to end my Graves' disease? So definitely not. I mean, a lot of people on this call, I assume, between here and the YouTube channel that we're live streaming to, have Graves, and there might be a few that are here that maybe they did receive radioactive iodine, but again, my story, I had Graves' disease, didn't receive radioactive iodine, and that's my goal when working with patients, is to have them avoid radioactive iodine thyroid surgery. So yeah, quick answer to your question is no. You just need to do things ideally to address two things. You want to be safe. So you do want to, so we want to address the cause of the problem. So I'll say that. But then while doing that, you want to be safe while managing the symptoms. So you don't want to just, you don't want to just be taking, I mean, you don't want uncontrolled hyperthyroidism. So that's, yeah. So yeah, you want to, if you can't take antithyroid medication, sometimes that could be a challenge, but then there's bugleweed, and there's also, so bugleweed is, and then cholestyramine, for someone who, can't, if the bugleweed's not effective and the antithyroid medication. So there are other options, but again, if someone has to be on the antithyroid medication, then of course be on the, again, risk versus benefits. It's, even if it causes like a lot of side effects, again, that might not be for you. But there are some people I've worked with who just refuse to go on antithyroid medication just because they read about the side effects. And again, they're true, but not everybody experiences, those side effects. So, so, and like I said, everything's risk versus benefits. So yeah, if I was on bugleweed, if bugleweed did not work, I would have been on antithyroid medication. If it was between that and getting radioactive iodine or thyroid surgery, there's no question I'd be taking that. And if that didn't work, or if I was getting side effects, I'd look into something else. I mean, I'm not saying there's never a time and place for conventional medicine, like, I've already said that with the antithyroid medication, but even like thyroid surgery, some people do need to get, other, yeah, sometimes they do need to do it, but most people do not. So So yeah. All right, so I just want to say how disheartening it is that conventional doctors, my endocrinologist adamantly says that hyperthyroidism can't be healed naturally. I adamantly disagree. So so yeah, no, I agree. I agree. It's sad that, you know, I mean, for both Graves and Hashimoto's, where they just say, you know, just either take anti-thyroid medication or radioactive iodine, or just if you have Hashimoto's, just take thyroid hormone replacements, and that's all they do. But yeah, I agree. All right, so BH here. So good day from New Jersey. Can you go over the pros and cons of natural versus synthetic meds for those with Hashis, so Hashimoto's? Also, have you had experience with camel's milk in helping those with thyroid disease? I have not had experience with camel's milk helping those with thyroid disease. But as far as pros and cons of natural versus synthetic medication, a little bit more challenging these days because, again, there's been like reformulations, and not, you know, some people don't do well with, you know, different types of desiccated thyroid. But so, you know, so synthetic thyroid, like levo, you know, like Synthroid is most commonly taken. That's synthetic T4, and there's Cytomel, which is synthetic T3. And then there's desiccated like Armor, Nature-Throid, WP thyroid, NP thyroid, which is T3, T4, also T1, T2, calcitonin. We really don't still know like the full functions of T1, T2, um, but I mean, the benefit of taking the natural, the desiccated, is that it has both T3 and T4, and other, you know, that mentioned the T1, T2, calcitonin. I mean, just it's more like your thyroid hormone. Um, you know, I guess the disadvantage, again, now the disadvantage is some people just don't seem to do well with them with the reformulation. I mean, in a very small percentage, some people form antibodies, oral antibodies against like you know, the porcine T3, T4. um you know, so that's and then also another disadvantage, it can be more challenging to get a prescription by your medical doctor for desiccated thyroid hormone. So you might have to go to, I mean, sometimes have to go to like a natural healthcare practitioner, functional medicine practitioner. You know, synthetic, the downside is, again, it's just T4, and you know, a lot of people have problems converting T4 to T3. So if that's the case, now they could take Cytomel like T3, you know, to help with that. But, you know, and then also you know, usually like Synthroid, I know there's a lot of fillers, and, you know, depending on the dosage you take, artificial ingredients. Um, you know, so yeah, just and then, you know, but the benefits is, I mean, usually the benefit, it could be covered by insurance, and some people do okay with with that, so it might be lower cost, and not everybody does bad on there. There's also hypoallergenic forms such as Tirosint. Um, you know, so which, again, not, some people seem to do better with the Synthroid, even though I'm not a big fan of it. But, you know, if someone's doing well in Synthroid, again, I'm not going to tell them to stop taking it, but the goal is to try to get them hopefully to the point where they don't need it. But some people do need to take thyroid hormone replacement permanently, like I said. So I don't want to give anybody an impression that, you know, everybody with Hashimoto's can stop taking thyroid hormone, or, you know, definitely not abruptly, like I mentioned earlier. So all right, so another question. I have Graves, and I'm on PTU, and I started taking a more natural healing route, but they have me taking the supplements and don't want me to completely stop the thyroid medication yet. Is this safe? I'm almost a month in. So again, I can't, I mean, I can't say every single supplement is safe, but, you know, all I'll say is that I've had patients on Methymizole, I've had patients on PTU, and I've had them take different types of supplements without a problem. You know, does that mean everybody, you know, again, everybody's different, but it doesn't mean that you can't take anything, you know, but like I said, this is a case, cases like this, like really specific, where you might want to consider working with someone. But I will say, like I said, I have people who are on anti-thyroid meds all the time, and, you know, I give them supplements, um, and usually there's not a problem. I mean, with other medications, like if someone's on blood thinners, like warfarin, then there's, again, there's more, drug nutrient, drug herb interactions that you got to be cautious. So, all right. Again, a lot of questions. I'm trying to get to as many unique people I could get to here. Nice. Okay, so let's see. What I'll do, I'll answer this and then I'll try to remember to go to YouTube and answer another couple of questions and go back to Zoom. So Ayelet, from your experience, is there a connection between Hashimoto's and granuloma annulara? I honestly do not know. I wish I had all the answers. I am not, I don't know. I am sorry, but I don't know if there is a connection or not, so I apologize. All right, so let me go to YouTube, like I said, and try to get a few questions there, and then I will go back to Zoom here. All right, so Terry, how do you taper down meds? My doctor is not pro natural remedies. I started taking 5 milligrams methimazole. Now I'm taking, is it 25 milligrams? I don't know if there's a period, like 2.5 milligrams. I'm currently in okay, assume you're taking 2.5 because the next sentence you said, I'm currently in remission. So, which 25 milligrams. Yeah. Anyway, so I'm guessing you're on, if you started taking 5 milligrams, now I'm taking 2.5 milligrams, and that would make sense. So, I mean, you already tapered down the med, so you can't really go much lower than 2.5 milligrams of the methimazole. I mean, some people will do it like a few times per week. Like if they're doing it, 7 days per week, they might, take it like, Monday, Wednesday, Friday, like for example. Again, I'm not telling you to do that, but and again, just hopefully, you said your doctor is not pro natural remedies, but I know you're on paleo keto. Hopefully you were doing some other things also to address the cause of the problem. Because again, there is that risk of it returning if that's the case. But if you haven't done anything, like I said, some practitioners will, just have someone stop once they're, if they're looking good. Also antibodies, I will say, look at the antibodies in the case of Graves, thyroid stimulating immunoglobulins, even though again, you could have other antibodies too. But if everything's normal, just ask the prescribing doctor if you could, start, if you could either stop it or ask the prescribing doctor if you could, take it every other day. And so Heather here, Heather says, I believe I have hyperactive thyroid. What kind of test is it the doctor needs to run? Is it the TSH full panel test, blood work? I've had it done before, but levels came back normal. I do not feel good. Yeah, so what I would do is I would run TSH, free T3, free T4. Might as well run reverse T3. I don't always do that in my hyperthyroid patients, but you said if it's come back normal in the past. I'm wondering, you could have Hashitoxicosis, which again, you would figure you would still have hyperthyroidism, but that's associated with Hashimoto. So I would get all 3 antibodies tested, Heather. I would say to get thyroid stimulating immunoglobulins, which are associated with Graves, anti-thyroid globulin antibodies, thyroid peroxidase antibodies, just see if there's anything, autoimmune showing up. And then, still want to do basics like, just meaning like CBC, complete blood count with differential, comprehensive metabolic panel, lipid panel, just, but also could be other things like feeling that way. You could have like a infection, which again, maybe a CBC with differential might give some information, that you might feel like you have hyperactive thyroid with an infection, or, adrenal problems, especially like higher, like problems with higher cortisol levels. So those are other things to look at. Again, adrenals, usually I recommend either saliva testing or dried urine testing, which they probably won't do at the doctor's office. But those are the blood tests I would start with, and see what that shows. And then if everything looks normal, you might need to go outside of the blood test and dig deeper. right, so Pamela here, histamine levels are always high. Antihistamines are starting to hurt my stomach. Suggestions? Well, I mean, there's natural antihistamines like quercetin, for example. You know, you could take like a DAO supplements, you know, to break, you know, helping to break down histamine. But, you know, try to address the cause of the histamine problem. So, I mean, it's usually coming from the gut. So if someone has like SIBO, small intestinal bacterial overgrowth, you know, that could be a factor, but there could be other imbalances, other, you know, types of dysbiosis. Um, so, um, so yeah, that's what I would do. I mean, again, like I said, there are natural options. So if you're taking like prescription antihistamines, then you can look into other, you know, more natural like quercetin or a DAO supplement, you know, or some things to come to mind. But all right. All right. So Saeed, I'll answer. Okay, so two questions here. This is a quick one. Teresa, do you have a book about healthy gut biome? No, not specifically. I mean, do talk about it in my Hashimoto's Triggers book, probably also my Graves. It's been a while since again, a long time since I've written my book, so I forget I probably don't go as deep into the microbiome again. Yeah, another reason to come up with a updated one, but more so, but I don't have like a specific book on like the gut microbiome. Um, and then so Saeed, I'll answer this and I'll go back to Zoom. So Saeed, I am having hypothyroidism, taking 150 milligrams plus 12.5 thyroxine tablets. It comes below for some time. After a few days, it goes up to above 12. So I guess you mean your TSH, suffering from terrible itching. Um, Yes, and I do have an article on itching. It's immune. It's not thyroid, but immune. So you probably have Hashimoto's, but you want to get those antibodies tested. And then hypothyroid, the same person, Saeed, implicating on high LDL. So yeah, someone has low thyroid hormone levels, it's very common to have high cholesterol. And this could be from someone with Hashimoto's or someone with Graves taking anti-thyroid meds. Very, very common to you know, when thyroid hormone, I get this question a lot from patients too, where they're taking the anti-thyroid medication or maybe bugleweed, and they, you know, more so with anti-thyroid medication, well, they'll become hypo on the hypo side, and cholesterol, LDL are high. So yeah, but I also would look at those antibodies, i.e. just, you know, just to, you know, it sounds like you might have, I mean, most people with hypothyroidism have Hashimoto's, and just again, it is more of an immune system condition. So it is, you know, probably important to take the thyroid hormone replacement, but you also want to do things to address the autoimmune component. All right, so let's go back to Zoom. And again, I'll go another like 16 minutes here. And again, I apologize in advance for not getting to everyone. Just like I said, I'll do some more of these. You know, just, but let's see. So MJ here, I'm trying to conceive, and my RE recommends taking Tirosint since my TSH has been fluctuating between 2.5 and 3.9. My TPO has been as low as 9, and then right now it's 166. If I take the Tirosint, can I get off of it easily after I get pregnant and have the baby? Yeah, not necessarily. I won't say you could get off of it easily. I mean, you know, if you have, I mean, and some women it'll like flare up, they'll have like postpartum thyroiditis. So it depends on your situation. And again, it also depends on how much Tirosint you're taking. You know, if you're taking like a low dose, like, you know, 25 to 50 micrograms, it'll be, you know, probably easier than someone with a higher dose. But yeah, so that really depends. I mean, your TSH isn't crazy high, like 2.5 to 3.9. But again, can understand, since trying to conceive, and, you know, healthy thyroid hormone health is important for a healthy baby. And so yeah, I don't want to say with certainty you'll be able to get off of it easily. It really depends on the situation. But if you are in a lower dose, it'll, you know, typically be easier than on a higher dose. Oh, and actually, speaking of postpartum thyroiditis, we have we have a question on Rox about Roxy. Do you know about postpartum thyroiditis? I'm 11 weeks postpartum and have symptoms and blood work showing I've gone from Hashimoto's to hyperthyroid with intense anxiety, heart palpitations, and hot flashes. Do you have experience with this? And what approach, what program, what book should I look at when I have such a rare condition? Thank you. So, two resources I'll lead you to. So, one, I do have a chapter on postpartum thyroiditis in my Hashimoto's triggers book, just because it's not really a trigger, but because people will have the autoantibodies, they'll have the autoimmune response before it'll seem like a trigger, but the giving birth is not really the trigger. You could think of it as a straw that broke the camel's back, but something else. Yeah. So anyway, read that, my book, that chapter. And again, there's other things in the book that'll benefit you. But then also there's an article I wrote. I think I wrote an article on postpartum thyroiditis. So you could also check that out on my website. But also Hashitoxicosis, which again, that's when someone has Hashimoto's with the symptoms of hyperthyroidism, which, just, yeah, I mean, most doctors aren't going to give anti-thyroid medication because it's not a true it's usually a transient hyperthyroid state, so they might give like beta blockers. There's some natural things if but again, not to say that you shouldn't take the beta blockers, but yeah, just check out again, go to my website, naturalendocrinesolutions.com. There's a little search bar, and you could just do a search for postpartum thyroiditis and Hashitoxicosis, and maybe you might get enough information there. If not, you could check out my book, and there's a chapter on postpartum thyroiditis. All right, so my endo believes my hyperthyroidism was caused by COVID. I believe I had it in February, so it's not in my family history at all. I am tackling this with every supplement you recommend, and I do not want to take the meds anymore. How do I properly do this? So very interesting timing, because I mentioned I wrote an article on Thursday, and it was an update on the virus, and I spoke about how now there's research out that shows that there's a few different things I wrote. So check out the blog post for more information. But I wrote about how it could be a factor with subacute thyroiditis. So that's what it sounds like with you. Now, that's a long time, February. And if you're still hyper right now, that's like what, 7-8 months. Subacute thyroiditis usually doesn't last that long. So, but again, I mentioned, that's why I spoke about the black cumin, which might be something to consider. But I would get the Graves' disease antibodies tested. So, again, there's nothing in the research I was able to find with COVID triggering like Graves' or Hashimoto's. But like I said, it can be a factor with subacute thyroiditis. There's some research there now, so which is in the Thursday blog post. And again, I mentioned black cumin because there is some research showing that black cumin can help with COVID. So specifically, so I'm not saying that's the solution. There's a lot of things like vitamin C. I also included a link to an early blog post this year I wrote on different things to help support immune system, which a lot of people are already aware of, like zinc and vitamin C and selenium, and resveratrol that has antiviral properties, also inflammatory. So that's something also to consider. But like I said, I would also just check thyroid stimulating immunoglobulin just to see if, maybe, again, there's still, it's new, but there's been other coronaviruses too. And I don't think I've written about that as well when COVID first came out. And I don't think there's any correlation between that being a direct trigger of Graves' or Hashimoto's, but again, that's a long time to have subacute thyroiditis. So like I would say, and then if you don't want to take the meds anymore, there are things like bugleweed and all that, but again, risk versus benefit. So it's just, And again, this is a situation maybe to work with someone. And when I say work with someone, I'm not saying, I'm not trying to plug myself. There's other doctors too. I'm just saying that, it's hard sometimes to give recommendations. I could say, in this situation, well, if you don't want to take the meds, I mentioned I took bugleweed, and maybe bugleweed, could help if it's subacute thyroiditis. Yeah, again, usually temporary, so you just got to be careful. Look out for hypo symptoms, because usually you eventually become hypo. But if it is Graves, you want to address the immune system. And just viruses. Just think again, viruses are more immune system problems. Think of it that way. Sometimes you do need to treat the virus, but you want to do everything you can to improve immune system health. So I mentioned some supplements, but healthy diet, stress management, proper sleep. I mean, don't overlook the basics. It's not just about taking supplements. So yeah, make sure, so ideally work with someone, but at least incorporate basics. And then, again, maybe on top of that, do some things from a supplement perspective. All right, we're going to answer a few more. And like I said, I know I've apologized multiple times. I just didn't expect. Usually I don't get this many. This is like the most questions I think I've had in one of these calls. And yeah, but if I have a few more of these this month, again, my Saturdays are a little bit busy, so it might be like during the week, like different days, but we'll see. I might have something next Saturday. If not, I might be able to get one in, but just because I know Saturdays work well for a lot of people. But so Natasha, my daughter has Hashimoto's and a thyroid nodule cyst. She was put on a strict diet 2 years ago, and her TPO dropped from 200 to 150. Her thyroglobulin antibody is less than 1, but her nodule is still growing. What can I do? So yeah, nodules. Have a number of different articles, blog posts on nodules. Typically, estrogen dominance, problems with estrogen metabolism, insulin resistance, are things to really focus on. So it's not addressing the autoimmune component usually won't address the nodule. And nodules sometimes are tricky. So nodules they can be challenging. I work with people with nodules, and there's not a specific like protocol where you just do this. And so usually I am testing to see if someone has problems with estrogen metabolism, like using like dry urine testing for that, for example. Insulin resistance, you could do like just blood testing, like look at fasting insulin, hemoglobin A1C. And a lot of people know that they already have insulin resistance. Not to say everybody has insulin resistance when they have nodules, but those are some of the things to really look into, and to just address those problems. Because and sometimes it can be challenging with nodules. Nodules aren't always a problem, but yeah, I would be concerned if it's growing, especially if it's large, if it's greater than 1 centimeter, and especially if it's like 2 centimeters or greater, then I'd be more concerned. All right. Someone else said, I'm curious with Julie Mills. I believe I had COVID late last year. So hopefully I answered your question. And someone mentioned Tepeza, like it was told that Tepeza treatment costs $500,000. So I heard, yeah, and that's for thyroid eye disease infusions. I've had a few patients take it now. One patient told me it was 300,000. So not quite 500,000, but still probably out of most people's budget. But again, that might have been the insurance cost, like what insurance is billing. But even if the out of pocket was like 1/10, was like 30,000 or 50,000, I mean, that's still, a lot of people can't afford that. But yeah, so I have heard it is expensive. All right, so it's just again trying to. How long does it typically take to go into remission? I mean, it depends. I mean, I would say on average, like 9 to 15 months. And then, even after that, like, it took me like about 9 months before getting not really into remission, but where everything looked good. But arguably you want to see a few blood tests, make sure everything is stable. So more, so again, a year is like an average number, but some people longer, some people, a little bit shorter. So it's, but again, of course, it's not going to take that much time to see progress, as you make changes to your health, make improvements to your health in diet, lifestyle. But again, a lot of times you need to dig deeper into looking into other triggers. But even then, again, it's not, I mean, again, some people are some cases are more challenging than others. I'll say that, but it's not a few month process. And even if you're doing the conventional medical treatment, which isn't really the true state of remission, they'll usually have you on antithyroid meds for, like, again, 18 months to 2 years. And that, is not doing anything for the cause of the problem. All right. All right, Rupa, I'm not sure so requests take us through the main blood test given for Graves or Hashimoto's. Okay, so I kind of recommended, thyroid panel, TSH, free T3, free T4, maybe reverse T3, antibodies, so thyroid stimulating immunoglobulins for Graves, anti-thyroid globulin, anti-TPO antibodies for Hashimoto's, CBC with differential, comprehensive metabolic panel, lipid panel, 25 hydroxy vitamin D, maybe C-reactive protein, so those are some. And then you mentioned something about nightshades, but I think your question was cut off because you said how do so I'm not sure, but I do have an article on nightshades. If you visit my website, type in nightshades, you can learn more about that. All right, so Stephanie, how many years can you take a low dose of methimazole to avoid radioactive iodine? In the United States, typically it'll be 1.5 to 2 years, but there are some endocrinologists, especially in other countries, where they'll have someone on 5 milligrams of methimazole, because again, they're not doing anything just to cause it a problem, but they're still trying to have their patients avoid radioactive iodine, trying to preserve their thyroid health, their patients' thyroid health. And they'll have them on it for years, like 5+ years. And honestly, if I had a choice to take 5 milligrams, I mean, this isn't ideal, but if I had a choice, be on 5 milligrams methimazole permanently or get radioactive iodine at thyroid surgery, and as long as I was tolerating the methimazole and liver enzymes look good and CBC, white blood cell count look good, I would do it. I mean, again, that's not what I look at with my patients, but like, that's not the goal. But if it was between low dose methimazole or getting my thyroid removed or obliterated, I would choose the low dose methimazole. The problem is, again, in the United States, many doctors would not be willing to do that. So you'd have to try to find one who is open-minded. All right, I can't, RVE, Rivi. Do you know what causes hair loss? What is the mechanism of deficiencies? So, I mean, hair loss, very common with both hyper and hypothyroidism, more so with hyper, I see it, but I see it with both my Graves and Hashimoto's patients. But hyperthyroidism, it seems like it's more common and a lot of times worse. So you want to balance thyroid hormone levels. Even when doing that, it's usually not, I mean, it takes time. Just like when it's in balance, it could take a few months. So it's not that it's not enough, but it's not like just getting it in balance and right away is going to correct the hair loss problem. The good news, usually it almost always resolves. And, when the thyroid hormone levels are normal, almost always resolves, and the hair almost always grows back. But there also could be nutrient deficiencies too, biotin, selenium, even too much selenium could also cause hair loss. Iron, low iron, GLA, gamma linolenic acid, which is why some people take evening primrose oil or borage oil. So definitely nutrients. And remember, if you have a lot of nutrient deficiencies, it's probably due to problems with gut health. So improving gut health. All right, so So hold on here. So Pauline, I'm hyper with low body temperature of 36.3 degrees Celsius. Is this unusual? I don't really know if I have Graves or Hashimoto. I mean, with Hashimoto's, it's not uncommon, like to have, low like basal body temperature. So yeah, not so much with Graves, but again, well, you said you're hyper. You could also have the Hashitoxicosis, even though, again, if you're hyper, that's yeah, I wouldn't say that that's as common. Okay, L-Carnitine. So Stephanie asked about L-Carnitine. So yeah, L-Carnitine in higher doses that has antithyroid properties. So like in the literature, it shows like 2,000 to 4,000 milligrams could help. In some, I usually go to bugleweed first. I just find that to be more effective. But in some patients, I'll also I'll recommend bugleweed, and sometimes recommend L-carnitine. Some people just take it on their own. They'll read about it and say, okay, I'm going to take L-carnitine. And but if someone is really like their thyroid hormone levels are really high, then and let's say bugleweed is working but not, they need some more help, then maybe taking L-carnitine is something to consider. But again, it's the large, it usually comes in like 500 milligrams, and that's 500 1,000 milligrams just usually isn't enough. And someone here just received Tepeza. Frank said, I had orbital decompression surgery to restore my vision. Just completed the last 8 treatments with Tepeza. Swelling has improved. Double vision is almost gone. Eyesight is clearing. So that's great. I had one person I had with, again, I've had a few people on with Tepeza. So one person, one is still undergoing the treatments. The other person I think is done. And like the eye cosmetic changes are greatly improved, but he's had double vision, and the double vision has not. So everybody is different. I mean, if insurance covers it, and if you have like severe thyroid eye disease, it might, definitely might be something to consider doing. I mean, that's great, Frank. Thanks for sharing that. Yeah, I'm gonna wrap it up soon. Just seeing if there's like questions, especially that could like benefit. And some of these are just like what does one do to lower high thyroid antibodies? Thyroid blood is in range, except the antibodies off the charts. And again, this I could spend a whole webinar, just a lecture talking about that. But just again, find, remove triggers, healing the gut, just correcting other imbalances like nutrient deficiencies, are important. So I wake up every night with sweating so much I need to change my PJs and pillowcases. This is a matter of thyroid disease. So yeah, I mean, it sounds like it might be hyperthyroidism. I mean, it could be also like, like perimenopause, postmenopause, depending on your age. But yeah, hyperthyroidism. Not everybody. It wasn't that bad with me, but some people, they get it confused. Like women around the perimenopause, postmenopausal age will get, not sure if it's like, due to the hormones, like sex hormones, or due to, the thyroid hormones. But, all right. All right, another one with hair loss. All right. Shall I remove my thyroid if I have Graves, Hashimoto's, and thyroid eye disease where I may go blind? I mean, everything's risk versus benefits. So if someone has severe thyroid eye disease, again, maybe the Tepeza is something if you're in the United States and you have health insurance to cover it, and if the concern is a thyroid eye disease, then that might be something to consider. If you know, if that's not the case, and if you're concerned, you know, like, you know, as far as the thyroid eye disease, I mean, I definitely wouldn't get radioactive iodine, which most doctors wouldn't do it if so, wouldn't recommend radioactive iodine for someone who has thyroid eye disease. You know, surgery, you know, maybe. I mean, that's, again, I would, assuming you've done other things to help with the immune system, you know, like if you just went to your endocrinologist and, you know, I mean, but again, if someone has severe thyroid eye disease, like I said, that's not always going to respond to a natural treatment approach. So I would never talk someone out of, like, if they're like leaning towards thyroid surgery, where it's like really severe and the, you know, the doctors, like they're seeing an ophthalmologist, and the ophthalmologist is saying you might lose your vision. You know, if it's that severe, then again, maybe in some cases, you know, just do, you know, surgery might be the best option. Again, the TEPEZA, if you're able to, that also might be something to inquire about. You know, if most people aren't in that severe of a case, so I would say definitely look into more of a natural approach to, or, you know, in some cases, maybe even LDN, something like that. Try low dose naltrexone. Again, it's more hit or miss, but you should notice relatively quickly, and you could take it and see if that's helping, you know, even though it's not addressing the cause of the problem. But again, in this case, looking for quick answers to try to maybe save your thyroid, you know, where again, a natural treatment approach takes some time. So, so yeah, that's what I would recommend. And all right, and then yeah, I mean, here's an example. I'll just say this. I mean, this here, JJ. I had radioactive iodine 5 years ago and still don't have my life back. Back then, I had no choice but to submit to the medical model to kill my thyroid, as bugoid did not work for me, and I was hospitalized for 9 days as I was allergic to methimazole, and my resting heart rate was 120 beats per minute for about 6 months. T4 is not working for me as I still have the post-treatment ailments. Let's see, I can't. That's what I don't like about the Zoom chat. It's hard to see. Treatment ailments like air hunger, fatigue, adrenals have been tested, look good. Suggestions, thank you, and all the antibodies. And are the antibodies different between Hashimoto's and Graves? Yeah, so like I said, I mean, some people, it's not uncommon to have all three, um, but yeah, thyroid stimulating immunoglobulins for Graves, and then anti-thyroid globulin antibodies and anti-thyroid peroxidase for Hashimoto's, even though TPO antibody is also very common with Graves. But so, yeah, I mean, definitely look into the immune system. I mean, it does become a challenge once someone receives radioactive iodine and thyroid surgery. There are still things I could do or others could do, you know, not just me, but it's obviously like if someone gets, their thyroid completely removed, we can't remove their, I mean, we can't restore the thyroid health. If someone gets radioactive iodine, you know, a lot of times the same thing, but there's still that immune system. But yeah, the T4. So maybe think about desiccated thyroid, you know, because again, you might have problems converting T4 to T3. So look into maybe desiccated thyroid, you know, so you get in the active form of T3 to help. But yeah, because if you've tried, and it could be maybe just a different type of T4, but if you tried different brands of like Synthroid didn't work, so you tried others and they didn't work, Tirosins, again, maybe try like a desiccated thyroid hormone with that. But, you know, obviously that's not getting to the cause of the problem but in your case, even addressing the immune system component, that might help in this situation, but it also might be, it sounds like if T4 is not working, like, you know, you know, if your thyroid is still, you know, like if your TSH is on the higher side and your, you know, T4, T3 on the lower side, you know, it might be, you know, desiccated thyroid that you need. Again, definitely a situation where you also might want to look into working with someone. Okay, are greater than 4,000 antibodies a problem? Not necessary. I mean, it's not good, but it's not like the higher the, I mean, we don't want really high. With Graves, definitely higher antibodies are more of a problem. Usually if someone has higher TSI, they're more likely to have thyroid eye disease. I mean, I don't like to see someone with real like antibodies in the thousands. But I won't mean, it doesn't mean that they have like more, you know, more damage like happening to the thyroid gland just because the antibodies are high. But obviously we want to, you know, whether it's 400 or 4,000, we still want to normalize. We still want to address the immune system. So, Um, Diane, if your T3 and T4 are normal, how high can your TSH go before medication is recommended? I mean, it depends on the doctor. A lot of times they won't recommend any medication unless if TSH is red flagged on a blood test. So if TSH is like someone else gave an example of 4.8, which is definitely above the optimal range, but if the lab has an upper range of 5, the doctor may not recommend thyroid hormone. So if you go to a functional medicine practitioner and if your TSH is like 3, and again, obviously, just assume you're having some type of symptoms, like if your T3 and T4 are normal, or maybe not. I guess you don't have to have symptoms, but if someone has a TSH of 3 and they're not having symptoms, and everything looks good, they might, medication might not be necessary. But if you're symptomatic, TSH is, let's say, a 3, 3.5, and definitely get those antibodies tested because, just want to try to do more than just take thyroid hormone medication. All right, so Charlene, I have Graves for 30 years. Wow, that's a long time. Gastric reflux, hiatal hernia, bloating and gas, feel miserable. Yeah, I am sorry. I wish there was like a quick solution, but I mean, definitely gut health, focus on, you might probably have seen like gastroenterologist and got an endoscopy and colonoscopy and all that stuff. But maybe not, but you could have things like H. pylori, which sometimes you could get false negative results. They might do a test, comes back negative, and they say, oh, everything's good, but you might have it. So if you're having all those symptoms, but definitely would recommend, comprehensive stool panel, in a case like this. And, yeah, just, and again, working with a practitioner. Like I said, when I say work with a practitioner, it doesn't mean with me. There are others that, I know there's not a lot of practitioners that work with Graves' disease, but with these other problems like gastric reflux, hiatal hernia, bloating and gas, there's definitely other practitioners. All right, so I'm okay. So Marie, how does elevated aldosterone levels affect Hashimoto's? I'll refer you to an article I wrote on aldosterone. So just visit my website and type in aldosterone, do a search, and you'll find the answer. Okay, Laura Lee, my nurse practitioner says I have Hashimoto's and Graves. That is not possible, is it? It's possible to have the antibodies for both Graves and Hashimoto's. Again, that's actually common, but you're not going to be hyper and hypo at the same time. Now, some people might fluctuate between the two, but yeah, typically you're not going to be hyper and hypo at the same time. But yeah, having the antibodies for Graves and Hashimoto's is yeah, I won't say yeah, so having the antibodies for both is again common. So David, will this video be posted to YouTube? Yeah, I don't know if it gets posted. I think with YouTube there's a little bit of a delay. With Facebook, I could be wrong. I think Facebook, I mean that pretty much posts immediately when I live stream to Facebook. With YouTube, I think it takes like I don't think it's posted right away. I think it's like the next day when it's posted. I don't know why, but Ashley has some information for others. No question, just some information. I have Graves and have been taking Methymizole for 3 years. I went from 20 milligrams down to 2.5. I have to change my dosage depending on how I feel, but I've been controlling it with diet for the most part. I can't seem to completely come off because it will come back with a vengeance. So yeah, and again, ideally you don't want that situation, but if it's between that and radioactive iodine thyroid surgery, then, and again, I definitely would, if you haven't done so, just try to look into, finding, removing triggers, healing the gut, all those, that good stuff. Like I said, I make it sound easy, but I know it's not. But and I know some people do that and they still struggle. That means there's something missing, and it's not just diet. A lot of people will be like, I already did everything from a diet perspective. Maybe even followed autoimmune paleo diet, and I did that for a few months, and I'm still having problems. But again, diet isn't the only solution. So it's not, there's triggers other than food as well, and that's something I could chat about during the next call. So All right. Well, I've gone an hour and 45 minutes, and I am going to go ahead and call it a day. But, again, sorry I didn't get to everyone's questions. Like I said, I'll try to do this more often. Just just there's apparently, I guess, more demand than in the spring. Because when I did in the spring, maybe there were this many questions. I just don't remember as many. But anyway, just lets me. And they yeah, so there used to be with Zoom a way to unmute everybody to kind of say goodbye, but I think they changed everything because now there's just a mute all button, not an unmute button. But anyway, thank you everyone. Thanks for your questions. A lot of thank you are coming in at the end, and again, appreciate it. And again, if I didn't get to your question, again, I'm sorry, but definitely be on the lookout in your email. I'll be doing more of these. Not sure when. Again, probably spontaneous like this, where you get an email the day before with the day and time. But everyone, have a wonderful weekend, and again, I'll see you soon. And take care. And thanks for tuning in.